Okay, good afternoon, class. 1:14. It is afternoon on Friday. I wanted to take a moment and kind of go over this quiz that we had taken earlier today. I said I'd do a video lecture and on it, and I talked about really the importance of being able to identify respiratory failure versus severe respiratory distress. Okay, and so we had a lot of you guys this morning who just didn't treat the patient appropriately, and we got to get it right. Some of you did. I appreciate that, but I appreciate the ones that are still trying too. Okay, I mean, there's no sin in saying, yeah, I got it wrong. The sin is going to be not caring enough to get it right. Okay, so let's get it right. Let's go over it. You're dispatched to a person sick, difficulty in breathing. You arrive to find a 14-year-old female, Jenny Smith, has a history of asthma, which has been under relatively good control. However, Jenny slept over at a friend's house and awakened in the middle of the night with severe trouble breathing. So here we have a couple things. One, history of asthma. It's been under relatively good control, but now she's in a new environment. So anytime asthmatics, especially the ones that are asthma set off by allergic reactions, pet dandruff, different types of chemicals maybe used to clean carpet and that sort of thing, well, that can trigger an asthma attack. So Jenny is in a tripod position. She's using accessory muscles to breathe. She is conscious, airways open and patent. She's breathing 28 times per minute and labored. Chest rise and fall is 1 inch. Skin is warm and dry. Jenny has a radial pulse of 120, a blood pressure of 128/72. All right, so let's see what we have here just in this. So we have, she's conscious, her airway's open, and that's good. And it's patent. All right, 28 times per minute, so she's breathing kind of fast. The scenario says that her breathing is labored. It says that she is using accessory muscles to breathe. So in obvious distress at this point, if I'm reading this question, but her chest rise and fall is 1 inch. 1 inch is adequate. So she has adequate chest rise and fall, indicating her tidal volume is good, but she's using accessory muscles to breathe, and she's breathing fast. Will Jenny maintain adequate respirations? Will she maintain a chest rise and fall of 1 inch? No, she will not. If we don't do something pretty quick, Jenny will go into failure. Jenny's in pre-failure right now. She is well on her way to failure. She is knocking on failure's door. If we do not treat her aggressively, Jenny will slide right into failure. All right, so her skin's warm and dry. She has a radial pulse of 120, blood pressure of 128/72. Okay. All right, the scenario continues. It says you can assume the scene size up is complete and the scene is safe. Please provide the following information. What is the priority of transport? So I got a lot of you on this question. What is the priority of transport? And I think what you're thinking is, well, if I say it's high priority, then I really can't take time to treat her. We got to load and go. And that's just not the case. In your primary survey, you have identified a lot of problems. You have identified that she is using accessory muscles to breathe. You've identified a high respiratory rate. You've identified labored breathing, and We know that she's in a tripod position. If we had to suggest a breathing status for her, we would say that she's in severe distress. So she's going to be high priority. She will definitely be a high priority. All right, let's continue. Please provide the treatment plan for this patient. One that should include airway management. Okay, so we need to provide a plan for airway management and pharmacological therapy to include drug dosage. All right. So let's take a look at this. So airway management, she's on failure, so therefore BVM is out. But she's in severe distress. She needs the highest concentration of oxygen that we can provide to a patient who can still inspire. Does a nasal cannula provide the highest concentration of oxygen to a patient who can still inspire? And the answer to that is absolutely not. It does not. So therefore, we're going to go with a non-rebreather. And what I did notice, a lot of you guys, I don't know, some of you put 8 liters, and I think the reason why you did that is probably because you're thinking that you are going to give a breathing treatment. And that's fine. You could do that. But if you're going to put her on a non-rebreather while you prepare a breathing treatment, all right, through a small volume nebulizer, then you need to have the appropriate amount of oxygen coming through here. And so that's going to be at 15 liters per minute. Okay. And then what you can do is out here, you could put like small volume nebulizer, okay, at 8 liters per minute. But we've got, you know, if you went straight to a small volume nebulizer, 8 liters per minute, I'm good with that, okay? Because the sooner the better. But if you're thinking more realistically, you thought, well, and you know, in practical setting, it just depends on how quick you are with the drugs. So I would accept either one of those. Now, so that will, excuse me, that will handle the airway management problem there. Now we need to come up with a pharmacological therapy to include the drug dosage. So we know that asthma is causing bronchoconstriction. We need a drug that will provide the opposite, which is bronchial dilation. And we know by now that's going to be albuterol. All right, we know the drug dosage for that, or we should know. We just got done with that chapter. It's going to be 2.5 milligrams in 2 milliliters of fluid. And we're going to add some Atrovent . 0.5 in 2 milliliters of fluid. Milligrams there. All right. And so there's our drug dosage. Now, explain your rationale. That could be pretty simple. The rationale is, and I'm not going to write all of this out with my pen here. I'm just going to talk about it. But the rationale is this. Patient is not in respiratory failure. However, patient is in severe respiratory distress. Therefore, non-rebreather, 15 liters per minute. That's rationale number one. And the second rationale is going to be for my drug pharmacological therapy. And it's just what I said earlier. I need a bronchial dilator because I have bronchial constriction going on, and therefore albuterol and Atrovent will provide that. And that's it. We've got to get there. So let's look at another one real quick. All right, so your unit's dispatched to a local address for breathing problems. On the scene information is a boarding house. It's in an urban area. The patient lives in a one-room apartment. There are several other residents gathering at the entrance to the house and her room. You've been to this location multiple times for everything from domestic violence to routine sick calls. Okay, so right here, we probably need to consider scene safety and, you know, man, I cannot get this pen to write at all, and I need something different for this. But okay, so we just need to make a mental note. We've been here before. We know we've had issues here before. We might need to have PD on the way, just as a precaution. And we have plenty of places like that here in DeKalb. All right, as you enter the residence, for your general impression, okay? As you enter the residence, you immediately smell strong cigarette smoke. Okay, a middle-aged Alaskan Native woman is sitting on the bedside with her hands on her knees and her arms outstretched. She's in obvious respiratory distress. Her head bobs. Okay, her head bobs. That's kind of important. Bobs each time she exhales. Her skin appears dull and gray. She lazily rotates her head to you as you introduce yourself. There are several used and unused albuterol ampules on the nightstand. All right, what's that tell you? I don't know if you remember, but if you go back to chapter 10, it talks about signs of either respiratory failure or impending failure. And when you have head bobs, that means the patient's becoming extremely exhausted. And if they're not in failure, failure is very, very, very close. Okay, her skin appears gray. Oh yeah, what about the albuterol ampules there? That tells me that she's been trying to fix herself, possibly. She's trying to give herself albuterol, but it's not working. So what do we take albuterol for? Well, can be taken for respiratory distress, difficulty in breathing. It can be used for bronchitis, emphysema, a whole slew of COPD. We smelled cigarette smoke when we came in. So, it's quite possible that she's an emphysema patient. We don't know that, but it's possible. So let's continue with the scenario. LOC, as you approach the patient does not respond to questions. She appears very fatigued, although her eyes are open and tracking the activity in the room. So not good. Not good. We got head bobbing going on, and we got a decreased level of consciousness. She's not responding to us, but she's following us. I mean, she's too exhausted to even talk. That's a terrible sign to have. Chief complaint will be difficulty in breathing. All right. So let's move now to the primary assessment, and let's take a look at her airway. All right, so she has a nasal cannula on. Okay, so She's on home oxygen of some type, so that's leading me down that COPD road. Anytime you have somebody on home oxygen, there's something going on with them. It's more than likely COPD, but we're not completely sure. It could be, it could be something else. All right. She has a nasal cannula on and is open mouth breathing. Fish breathing, sometimes people call it. She is trying her best to get all this air in, and she's exhausted, and she just cannot inhale enough to get that air down, down to the alveoli, it sounds like. However, she does not speak to you and appears exhausted. She does cough weakly every 2 to 3 breaths. But the point is the airway's open. Breathing is extremely labored. She has obvious intercostal retractions. She has a supraclavicular accessory muscle use, but appears to have a small to limited tidal volume. If you do take the time at this point to listen to lung sounds, they're absent at the bases and minimally heard faint wheezing in the extreme upper fields. And the right, you think you hear a little something more in the right than you do the left. Okay. You have to immediately recognize at this point that this patient's in failure. Just going to put it right here. Respiratory failure. It's a clear picture of respiratory failure. She's breathing 34 times, 34 breaths per minute. So, nasal cannula is not going to work here. And I want you to always think about the nasal cannula as we're putting it on. When we put it on, it's because we think something could be wrong. It's not because the patient's displaying signs and symptoms of distress. Non-rebreather in this case, the patient is not inspiring enough to get the oxygen down to the alveoli, so that would just not, it wouldn't even help. Okay. We have to go PPV. Okay. And we're going to use a BVM for that. Okay. BVM. All right. This reads pretty clearly that she is conscious enough to where she'll have a gag reflex. So if we're bagging, we're gagging. She's going to have a gag. So what can we put in if the patient has a gag reflex? We could use a nasal airway, right? All right, so that's what we're going to do. We're going to use a nasal airway. All right, when we look at after her airway now is open and we are breathing, we are providing ventilation for her with hooked up to oxygen 15 liters per minute, and also nasal airway is in. We're ready now to move to C for circulation. The skin is grayish and dry, and radial pulses are bounding and fast. Remember, primary survey, it's never included the pulse rate, only that the patient has a pulse. Okay, and what does it feel like? Does it feel fast or slow? In this case, it's bounding and it's fast. Priority of this patient. We're going to treat this patient, okay, and we're going to make her a high priority. She's an extremely high priority because she's in respiratory failure. History is unknown, okay, but we can start looking around and kind of start picking up on a little bit about what could possibly be going on. Okay, so we know history is unknown from her, but maybe we find somebody that's there that maybe knows her. So we're going to do a sample. So signs and symptoms: labored respirations with difficulty in breathing. Allergies, they tell us that she doesn't have any allergies to medication. Meds include Provenal, Singulair, and lisinopril. So Provenal is the trade name for albuterol. Singulair is a medication that's given as a steroid. It's used to treat asthma. And lisinopril treats hypertension. Her past medical history, the P for sample, includes COPD, chronic bronchitis, hypertension, and alcoholism. Her last L for last known intake is unknown. And we have a little bit further on the events leading up to this. After the snow started, the boarding house owner turned on the heat, and she complained to the neighbors that was bothering her. She called EMS earlier in the evening, and they assisted her with a nebulizer treatment and gave her a shot, but she felt better and refused to go to the hospital. She woke up and called for a neighbor to call 911. So EMS apparently had been out earlier, and they assessed her, and she must have been in pretty bad shape then too, because they started treatment right away. And they say that they gave her a nebulizer treatment, okay, and that they gave her, let me erase that real quick, whoops, and that they gave her a shot. So I bet you they gave her a shot of epinephrine, probably a paramedic unit. Okay, and so they did that. She called it, yeah, and so it started working. Or she's been down this road a lot too, and she knew it was going to work in a couple of minutes, and so she started refusing treatment. That's very common. Not common to this degree where they're head bobbing. They're not going to refuse. It's too late. She's a high chance of cardiac arrest at this point. She is, I will call it an imminent cardiac arrest, because I think she's gotten so hypoxic at this point that we may not be able to turn her around. It's going to be interesting if we can. All right, so we got a set of vital signs here. Blood pressure of 164, and we'll go ahead and call the secondary assessment unremarkable. Maybe we'll call it we'll call it unremarkable, I guess. Blood pressure of 164/90. She has a heart rate of 124. She's breathing 34 times per minute. And I left the SAT in here to show you if you had on a non-rebreather, she only goes up to 88% from 84. That's nothing. So non-rebreather in this case, forget it. You're not helping things. Looks like she has a temp of 98.4. So, guys, we're out here to reduce pain and suffering and save lives. If you had treated her with a non-rebreather, you would have killed her, plain and simple, because you would have delayed the process of providing perfusion. She's hypoperfusing, and if you'd have put her on a non-rebreather while you're waiting on an ambulance to get there, she dies. No doubt in my mind, she dies. Can't make mistakes like that in the field. So, and there's not always going to be somebody there to tell you that you're wrong, that you shouldn't, that you need to treat her for failure. Sometimes you might be it. You're going to have to make that call sometimes, and you don't want to be the one who has to live with that, right? So let's don't do it. Let's treat people appropriately. It's too easy to understand the symptoms. It's too easy to look around, and it takes a little while in the field to be able to get good at, calming yourself down and noticing head bobbing and being able to raise that patient's shirt up and look at the rib cage, expose, and see that there's accessory muscle use. And to be able to look at their chest and decide there's less than 1 inch of chest rise and fall. That's why we're training now. And that's why we're so strict on, you got to get this. Because when you're in a situation where it's an uncontrolled environment, you've got to have that voice that comes out of your head that goes, okay, what did I learn in school? I learned head bobbing's bad. Does she have it? I learned that altered mental status could mean that, there's a high chance for airway embarrassment. I learned that if her airway's open, that's cool. We can move to breathing. I learned that, to look at the chest and watch for less than 1 inch of chest rise and fall. I've learned that I can make a high priority patient out of this, but still treat them. And so there we go. All right, guys, study this weekend. I promise you, till we all get this right, you will see this again and again and again and a little more. We will get this right. We will not go out to the field to provide care, not me being your instructor anyway, and getting this wrong. Okay. Have a good weekend, and I will see you guys next week.